Good morning, everyone. Thank you for inviting us to speak this morning. I think, as many of you know, FNS has a pretty ambitious research portfolio, and so I've been asked to answer some pretty specific questions in a limited amount of time, so bear with me. I saw a comic once, and since we're here close to Disneyland, I'll share it with you. It was a high school band director that said, "So great that we've been able to play at Disneyland, and I want everyone to go and have a great time." And the next panel says, "All right, everyone needs to be back at the bus in 30 minutes. So, so just like that, I feel like I've been given a big task, but I know that you will all bear with me. So I was asked to give a little bit of history of the WIC program, which I think a lot of the folks in this room are pretty familiar with, but since it's such a great story, it bears repeating. And to give how we define supplemental foods. And I think those two fit together so nicely that I'll share some context. The WIC mission, and I'm not a fan of reading things on the slide, but I think in this case it's a good thing to hear again. The mission is to safeguard the health of low-income women, infants, and children up to 5 who are at nutrition risk, by providing nutritious foods to supplement diets, information on healthy eating, and referrals to health care. And of course, breastfeeding promotion and support is a big part of that. And I'm emphasizing certain words here because this gets to the idea of supplemental foods. So what are supplemental foods, and what does that mean? And as I said, the history of WIC, I think, provides some really important context to defining what supplemental foods are. In the 1960s, there was growing concern about hunger and malnutrition among low-income populations. And so in 1968, a group of physicians met with what was then called the Department of Health, Education, and Welfare, along with USDA, and they were describing ailments specific to malnutrition and the types of physical and health problems that they were seeing in their patients, particularly low-income women, pregnant women, and children. And so the outgrowth of that were two simultaneous, though not planned together, but simultaneous activities. The first was that to build commissaries that would stock healthy foods, and then folks would go to their healthcare provider and get an actual prescription, much like we do with medically indicated drugs and pharmacies. Then they would take their prescription, and it was based on their specific health needs. And so what we were seeing was a lot of vitamin A deficiency, vitamin D, protein, calcium, and so forth. And so the foods were very targeted towards the nutrient deficiencies that were being seen in those groups. Simultaneously, I think everyone is very familiar with the story of Dr. David Page in Baltimore through his work at Hopkins, establishing a voucher program that ran in a similar way, where folks would take vouchers based on their own nutrient needs and get supplemental foods to ensure that they were getting the nutrients that were necessary. The outgrowth of this, WIC was formally authorized as a pilot in 1972. And these pilots are important because they formally established the link in WIC between an assessed nutritional risk and supplemental foods prescribed by a health practitioner in order to ensure that those specific nutrients were being addressed in the diet. So in 1975, WIC was established as a permanent program, and again, it's a long thing, but I think it bears kind of considering reading together, and that the establishing legislation said, Congress finds that substantial numbers of pregnant women, infants, and young children are at special risk in respect to their physical and mental health by reason of poor or inadequate nutrition or health care or both. It's therefore the purpose of the program to provide supplemental nutritious foods as an adjunct to good health during such critical times of growth and development in order to prevent the occurrence of health problems. And so supplemental foods were foods containing nutrients determined by nutritional research to be lacking in the diets of the program's target population. And so that's a critical part here, is that we're looking at research-based evidence to show what folks are eating and what folks' diets are lacking, and how these foods in the food packages can supplement those diets to ensure that the critical nutrients are being consumed. And to the extent possible, prescribed foods should assure that fat, sugar, and salt content is appropriate. So the background for the food packages, again, they're supplemental foods. They, as you know, the Food and Nutrition Service where I work and do research on all 15 programs. And so we also have this Supplemental Nutrition Assistance Program, which is a different program that folks can be a part of both. And that ability to be part of both was intentional in that the supplemental foods through WIC are not meant to be the entire diet. And so they are supposed to supplement the other foods that are supplied through your own purchasing as well as SNAP. The food package coupled with nutrition education, and that's an important piece too, are the chief means by which WIC affects the dietary quality. They are science-based, the dietary guidelines, and I see some of my colleagues here from USDA will be speaking next about the dietary guidelines, which are the foundation of all federal efforts on nutrition, and the American Academy of Pediatrics, of course, because those dietary guidelines until a few years from now only start at age 2. And as Rana mentioned, the last food package revision, also guided by the work of IOM in 2005, published in 2009, and became the interim rule in 2009 and a final rule in 2014, were the first revisions to the package since 1980. Now we have a mandate through the Healthy Hunger Free Kids Act to look at them again at least every 10 years. And so if we do our math, 2005 to 2015, when you all got started, is the 10 years. And so we are looking at wanting to ensure that as science is updated, that the food packages are updated to ensure that we are meeting the best needs with the best information available. So if we are thinking about what does this mean, examining nutritional risk, there are a couple of studies that are important to note that, as I mentioned, FNS has its own very ambitious research portfolio that works in tandem with the great work that folks in the committee and around the country are doing. The Infant Toddler Feeding Practices Study is a large endeavor that we are undertaking at FNS, which follows a nationally representative sample of infants born into the WIC program in the fall of 2013, and we'll follow them up through their 5th birthday. We are doing, it's a longitudinal study where we have contact with folks about every 3 months for the first 2 years, and then a little less frequently after that, but it's dietary recalls. It's asking their primary caregiver, usually their mom, a multitude of questions, including 24-hour dietary recalls, about how they are making decisions about feeding practices. This includes the choice of breastfeeding, timing of breastfeeding, duration, as well as the timing of the introduction of solids, which solids, the pattern of the introduction of solids, and then on through, up through age 5. And so the prenatal report is out. It's been published, and we are eagerly anticipating the year 1 report should be coming out hopefully in the next couple of months as well. But when we're thinking about nutrition risk, this cohort provides an interesting view. What I've circled here is that in that cohort, what we found was that 31% were experiencing low food security, which is the low food security is when someone in the household is fearful about resources not being sufficient, that they might have to skip meals. They're not quite skipping yet, but they're fearful that they may need to due to resources. Now, very low food security is when someone in the household is actually skipping meals due to low resources. And what we see here is in this cohort, those rates are quite high, 31% and 17% respectively. At the same time, what we see is that in that cohort, overweight and obese were 26 and 28% as well. And so when we're thinking about nutrition risk, this is some of the context in which the folks that we are seeing in the WIC clinics are experiencing. And again, this is a nationally representative sample of infants born into WIC in the fall of 2013. And so we'll be thinking about these things. Now, another study that we recently published was an analysis of NHANES data, which was based on the 2005 to 2008 cohort, which is important to note that this was before the implementation of the food package changes, the most recent food package changes. And what we saw was that we looked at three samples. We looked at WIC children, we looked at income-eligible non-participants, and the third group was higher income folks. And WIC children were more likely than their income-eligible non-participating peers and their higher income peers to be drinking whole milk rather than lower fat milks. They were consuming less whole fruit and more juice. They were less likely to consume vegetables as discrete items, and all of the groups had low whole grain consumption. And so again, these are, when we're thinking about nutrition risk and the eating patterns, it's important to be looking at what nutrients folks are consuming, what they may need to be supplementing in their diet. And so what you see in the 2014 final rule, which of course was implemented through the interim rule in 2009 based on the IOM suggestions, is informed by the data that we were seeing. There's a 30% increase in the dollar amount for children's fruit and vegetable purchases. It now allows parents to buy fresh fruits and vegetables as opposed to the jarred infant food if they choose. There's expanded whole grain options. There's a provision of yogurt and also soy products as milk substitutes. There's more flexibility to meet nutritional and cultural needs. And there's 3 breastfeeding-related packages in order to encourage breastfeeding. So now there's a fully breastfeeding package, a partially breastfeeding package, and a fully formula feeding package. So if we look at what does more flexibility at the state level mean to meet nutritional and cultural needs, we recently published, and I think this one's so recent, it was maybe 2 weeks ago, we published the Food Package Options Report, which is based on the participant characteristics report data, which was looking at, when given the flexibility, what types of flexibilities did states actually use. And so some context here is federal regulations will set out minimum requirements and maximum monthly allowances. These vary by participant group and food category. And within those regs, there is state flexibility for substitutions in the types and the forms of foods. And so an example here is that the maximum monthly allowance for the child packages for whole grains is 2 pounds, but within that, states can offer up to 5 different whole grain alternatives beyond whole grain bread. And so how does this play out? What we see is the bars are showing different types of whole grain products allowable for purchase by participant category in different states. And so I hope the font is big enough there, but you can see most states in the pregnant, the fully breastfeeding, the partially breastfeeding, and the children's packages, you're seeing just about everybody is offering whole wheat or whole grain bread. There's a lot of corn or whole wheat tortillas, a lot of brown rice, and then fewer states are offering oatmeal, bulgur, whole grain barley. And we also know that with the implementation of the final rule in 2014, we know that 29% of state agencies are offering whole wheat pasta as well in their packages. The flexibility with the cash value voucher or the cash value benefit is that states can choose to offer fresh fruits and vegetables. They can also offer frozen, canned, or dried. And so you see there, everybody is offering fresh in all of the packages. A majority of them are also offering frozen, but then fewer are offering canned, and even fewer are offering dried. Again, with the flexibility, you can see how states are offering different food package combinations. So we also recently published the WIC Food Packages Policy Options Study. This is, again, it's another study that we engage in pretty frequently, in that we do give the states, or try to give the states, quite a bit of flexibility. And so then we look at, when given that flexibility, what types of things are they doing? So 29% of state agencies added whole grain pasta, 39% are providing fresh fruits and vegetables as an alternative to jarred infant food. The proportion of state agencies offering frozen, canned, and dried fruits and vegetables increased by 9, 8, and 5 percentage points respectively with the implementation of the final rule. And the proportion of state agencies offering soy-based beverages and tofu as milk alternatives increased by 21 and 23 percentage points respectively. Again, this is after the implementation of the final rule. So key differences between the interim and the final rule. There are more low-sodium canned beans, there's peanut butter and canned vegetables. 72% of state agencies adopted the option for a certified professional authority to prescribe fat-reduced milk to 1-year-olds at risk of overweight and obesity. And they implemented various cost containment practices which are requiring the least cost brand for different categories of food. And so we see that 43% of state agencies require the least cost brand for milk, 35% for cheese, 38% for eggs, and in 67% of state agencies state that except for fruits and vegetables, organic products are not on the approved lists. As I said earlier, the food package and nutrition education are the chief means by which WIC affects dietary quality, so those are working in tandem together. And so I want to highlight a couple of other studies and to see how those play out. We did the WIC breastfeeding policy inventory, which was a census of state agencies and local agencies looking at breastfeeding policies that were implemented. And what we see here is that with the implementation of the new food packages, staff began being trained on using those food packages to promote breastfeeding. And so as well as, and you see there that 93% of state agencies and about 96% of the local agencies were training staff on how to use the food packages to promote breastfeeding. And so again, as I said, they're working hand in hand in tandem with one another to be able to do these things. And as Rana mentioned, we've seen breastfeeding rates increasing steadily over the years, and we believe that this interaction between the food packages and the nutrition education is an important component of that. We also see that in nearly all states are training staff on using the food packages to promote exclusive breastfeeding as well. What we also see is that breastfeeding promotion practices during the prenatal WIC enrollment, that most participants are being served by agencies that encourage them in the prenatal visit to enroll in their peer counseling programs. I will say, Rana mentioned that in the President's budget we asked for $80 million for the peer counseling program. As for those of you who are familiar with it, the funding for that has varied greatly over the past couple of years. It was 40, then it was 80, then it was 60. The President's budget asked for 80 again. But we recently published the WIC peer counseling report, and what that showed is that with the increased funding between the second report and the first report a few years prior, what we used to see is that about 45% of WIC participants were served in local agencies with the peer counseling program. The increase in funds, we now see that 87% of WIC participants are served by local agencies that offer a peer counseling program. And so, this is an important thing to know, that now most WIC participants are being served by agencies that offer this important resource. We see that they're including prenatal breastfeeding education classes in the prenatal visit. We're seeing providing individual breastfeeding counseling, in that most WIC participants are in agencies served by groups that have those resources. We also see how the food package and nutrition education are combining, in that when looking at policies for what happens when a participant on a fully breastfeeding package requests formula, I've highlighted a couple of things there, is that the participant may receive counseling about the benefits of breastfeeding, and the participant receives counseling about changing food packages. So again, they're using the food packages as a piece of the nutrition education in order to be able to encourage folks to be breastfeeding and hearing more about the food packages. And you see the numbers are, the percentages are quite high there. About 85% of state agencies and about 90% of the local agencies are using these practices. And as Rana mentioned, from the WIC-PC report, we know that the proportion of breastfeeding women now exceeds the proportion of non-breastfeeding postpartum women in WIC. And so we think that these are important components of looking at these two things interacting. Now, a couple of other key things to note. Again, these data are from the Infant Toddler Feeding Practices Prenatal Report. What we see over time, this is the second installment, but the first installment is about 20 years old. And so in the interim between that, what we see is a lot more positive beliefs about breastfeeding, those red bars. I guess I needed to choose a different color. And the second bar, sorry about that, but hopefully you can see the numbers. Between the first infant toddler feeding practices study and the second, that we're seeing a lot more positive beliefs about breastfeeding, that in response to positive responses to questions about breastfeeding is healthier, breastfeeding protects me and my baby, breastfeeding is easier, it brings my baby and me closer, and breastfeeding helps mom lose weight. So what you see is in all cases, a majority of women are responding positively to those, and in most cases it's a pretty high number, up in the 80s or close to the 80s. We also see less negative beliefs about breastfeeding. So in response to questions about breastfeeding ties you down, breastfeeding takes too much time, I'm worried about leaking breast milk, I don't want to feed in public, or breastfeeding is painful, again, we see that, except for that last one, less negative beliefs about breastfeeding. And like I said, this is the prenatal report, and so this is before women had their babies. We will have the 3-month, 5-month, 7-month, 9-month interviews come out in the year 1 report. And so what we can see is the difference between intention to breastfeed and then actual breastfeeding, and the duration of that breastfeeding if folks started, how long they were able to continue in the next report that will come out. And that one, I feel like it's a drum roll, that there will be multiple reports coming out of that one over the next couple of years, but year 1 should be out soon. So beliefs by sociodemographics, again, this is data from the infant toddler feeding practices, that African Americans were the least positive about breastfeeding, Hispanic folks were the most positive, the less educated respondents were, the less positive they were about breastfeeding. We did find that 59% of moms in the sample already had children, and of those, 82% had experience with breastfeeding. Where were they getting their advice about infant feeding? And again, this isn't just breastfeeding, but it's also, as I said, we're looking at timing of the introduction of solids, what's the pattern of the introduction of solids as well. That 68% are depending on WIC staff for getting advice. Of course, these are not exclusive numbers, as you can tell. A lot of folks are talking to their husbands or boyfriends. Some moms, about half are talking to doctors, about 40% are talking to friends, and about 40% are talking to other relatives. A key question here, though, is how important is advice from others to making decisions about breastfeeding and other and infant feeding, and what we see is that it's greater than 80%. So a lot of people are making their decisions based on advice that they're getting, and then we see when the prayer report where they're getting their advice from, and in some cases those are health professionals or trained people who know things about feeding, and other times they are not. So we also looked at the infant feeding intentions scale, and so you can see here the questions that go into that scale. And so, I'm planning to only formula feed my baby and do not plan to breastfeed at all. I'm planning to breastfeed my baby, or at least try, and so forth. And when we looked at that scale, what we find is that a higher intention to breastfeed among Hispanic women, married women, those with higher incomes, those who had previously breastfed, and those with more education. The lower intention to breastfeed on that same IFI scale, African American women had lower intention to breastfeed. If the woman was pregnant with a third or subsequent child, if they had been on WIC previously, they had lower intention to breastfeed. If they were not living with the baby's father, and if they were engaging in discussions about infant feeding plans with no more than one person. Again, this gets back to the advice slide from a couple of slides ago. Other things that had no impact on the intention to breastfeed: food security, which trimester they were in when they joined WIC, what their weight before pregnancy was, or if they were born in the United States. So we did regression modeling, and what we found was that the regression model was explaining about 34% of the variability in IFI scores, and that the socio-demographics and then the belief and advice or experiences with breastfeeding were explaining a good portion of the intention to breastfeed. And so again, what we saw was that some breastfeeding history had a positive impact on intention to breastfeed if they had more than a high school education, if they were living with the father of the baby. But if this was the second or later child, then it had a negative impact on, or negative coefficient in the regression as far as intention to breastfeed. If they, we had an index score of folks' beliefs about the benefits of breastfeeding, and so if it was a higher index, it was more positive. If there was a higher barriers index, which we had looked at earlier, then it was a negative association. And if they spoke with more than one person about their infant feeding plans, then it had a positive association with an intention to breastfeed. So the summary of just the infant toddler is that breastfeeding is viewed much more favorably than 20 years ago, and views on the benefits of breastfeeding as well as the advice that folks are getting have a really important impact on intention to breastfeed. And so some other research about the importance of the food packages, what we see, I feel like this is one of those, if you remember that old Kevin Costner movie, If You Build It, They Will Come. We changed the food packages, and not surprisingly what we saw was that people were eating the foods in those food packages. And so what we saw through lots of different research, this is not all out of FNS, it's about some of our peers, and I believe some of you sitting in this room, but increased consumption of whole grains and fruits and vegetables among WIC participants. Again, like I said, the food packages increased all of these things, and so what we see is, in fact, people are eating them when they have access to them. Consumption of whole milk decreased, low and reduced fat milk consumption increased. CDC looked at reductions in preschool age obesity in 19 states and territories, and found a pattern of reduced obesity rates. And while they couldn't attribute it to WIC, they did note WIC as a possible link for that because of the changes in the food packages. We also see rates of breastfeeding and the appropriate age of the introduction of solids improving with the introduction of the food packages. Increased availability of healthful foods, especially whole grains, fruits, and vegetables in smaller markets and convenience stores. And this, again, it's an important aspect, kind of what's driving what, but when we see that WIC makes changes, then the shopping environment changes as well. It has spillover effects for all consumers because, of course, the foods aren't exclusive to who can buy them in the store. If they're there, then other folks can have access to them. Also, postpartum WIC participation was associated with better subsequent maternal and infant birth outcomes, including higher average birth weights and lengths, lower risk of maternal obesity. So, excuse the tiny font on here, but this is just a list. As I said, FNS has quite a few studies ongoing right now. The biggest study is probably the infant toddler feeding practices study that's ongoing, and in a lot of the WIC clinics that folks here who may be part of that sample. But we're also beginning the National Survey of WIC Participants. Now, that is something we do about every 10 years. It is one of the benefits at FNS is that we are able to do work with nationally representative samples, which gives us a lot of strength in being able to look at the program nationwide. And so what the National Survey of WIC participants does is it gives us the kind of one opportunity to really talk with WIC participants themselves on a national scale about their experiences with the WIC program. And it's also in response to the Improper Payments Elimination and Recovery Act. So we do collect income information, and we're looking at certification error rates. But we will also be asking questions about the WIC experience. Rana mentioned, retention is a key thing that we are concerned about throughout the WIC program at the national level, as well as at our state and local partners, that after the first birthday, we see this continuous drop in participation. This gives us the opportunity to ask questions about that and talk to WIC participants about why are they leaving the program. We will have a sample of folks who are still in the program and a sample of folks who have left the program, and some may have returned. Infant toddler feeding practices study also allows us to do that, and so we will be getting some good information hopefully on retention and some critical factors there. The nutrition education study, that is again, it's a nationally representative sample of WIC agencies around the country, and how they have embodied or not the principles of VINA and RQNS as we have kind of changed the way nutrition education is implemented, and the guidance and the curriculum that is available to folks. How are they using that? How are they doing that in their clinics? And so that first phase 1 is a descriptive report. It is, I can say this, it's going through clearance now. Hopefully in the next month or so it will have passed clearance, but as any of you who have been eagerly awaiting a report from us know, sometimes that doesn't quite happen. But hopefully soon we will be able to publish that and start talking about the results. Phase 2 is what we are doing is testing if we wanted to do an impact evaluation of nutrition education, how best would we do that? Because folks who are familiar with nutrition education know that changes don't really happen immediately. It takes time, and how do we best measure that? And so it's an exploratory study where we're in 6 different sites testing kind of different ways to measure that. As I mentioned, infant toddler feeding practices. We have the WIC food package cost and cost containment report coming out, looking at what cost containment practices states are using. We have a Medicaid cost study looking at how much Medicaid, is there an impact on Medicaid costs from WIC participation? It's updating a study that we did in, I think, 1990 or something. We do a WIC eligibles annual update, the participant characteristics biennial report. We have the WIC nutrition services and administrative cost study, which is an in-depth study looking at how costs in state agencies are allocated, as well as comparing the administrative cost portion to other similar programs. We are looking at the peer grouping study, which is also known as the indicators of high risk study. WIC vendor management report goes in and looks at errors, payment errors at the vendor level every 5 years. We also have a grant for to the Baylor Center for WIC Nutrition Education Innovations, where they are trying to seed different innovations to providing nutrition education using technology. The UCLA Periconceptional Study grants, and as Rana mentioned, the WIC Special Project grants, where local agencies are partnering with university partners to do implementations of different things. This last round was focused on retention. The next round is focused on program integrity. New studies beginning this year. We will be doing another grants program for folks to do participant research to enhance WIC services. We are doing just some very preliminary legwork to see about the potential of EBT data and what we can do with EBT data at the federal level, as well as being able to offer it to other researchers. It's very exploratory at this stage. We will also be doing a testing of online ordering of WIC foods, and then another study using WIC infant toddler feeding practices data to see how well the breastfeeding packages and other are aligning with actual breastfeeding practice, so that it can then inform what we may need to know about the packages and how folks are using them. Before I go, I would be remiss not to note that on behalf of the Food and Nutrition Service and USDA, we wanted to recognize and remember the work of Gail Harrison. She is sorely missed, and I know that she was an important part of this committee as well, and so I wanted to take a moment to recognize that on behalf of USDA. Thank you. It looks like the clock has 1 minute and 23 seconds left, so I did it. Thank you. And I guess if you have questions, I will see what I'm able to answer. So thank you.